Hello, everyone. I'm Navid Ghaffarzadegan, a faculty member at Virginia State. Today, I'm reporting on a project that I've been doing for our university during the COVID-19 pandemic to help safer and healthier operation of the university. The paper is titled Model-Based Policymaking for Containing COVID-19 in Universities. During the COVID pandemic, many universities were facing the challenge of operation and to have their educational experience and keep the students safe. Many university presidents before fall 2020 announced their strategy of dealing with the disease. Some of them actually said that they're going to have their normal operation, and they predicted that it will have little effect on their operation. But later on, many of the same universities ended up closing earlier as they faced hundreds of cases in their universities, and they were worried about their students. Overall, in a country level, when we look at the United States data, we had about 400,000 cases just during the first semester during fall 2020. At Virginia Tech, there was a modeling group that was formed early on in the pandemic in April 2020. And the purpose of this modeling group, which was actually a relatively large size group, was to look at different problems that the university was facing about the pandemic, but also build the capacity of looking at similar questions later on as and help the university operation. This was an interdisciplinary group. We had experts from healthcare, from epidemiology, from different scientific fields. We got together on a weekly basis, and university administration was present in these meetings. They were presenting their challenges and their specific questions, and we were helping them with different modeling approaches and looking at different aspects of the problem. I was a member of this group. My own objective was to develop a simulation model of the spread of COVID-19 in a university context. And I was especially interested in considering behavioral phenomena that can exist in a university context, which can lead to different modes of spread of disease in a university. At different stages of the semester, I provided reports for the university, and especially before any semester, we were providing projections and policy suggestions for the university administration. In a very high level, the model included it was receiving data about COVID-19 and operational data. It was a system dynamics model that was representing the spread of the disease, very consistent with conventional ACIR models, and was providing projection and policy suggestions for the administration. Main inputs was, first of all, data from CDC about the characteristics of the virus, and also publish papers. Secondly, data from our own university about its population, its demographics, and different characteristics of the population as relevant to the spread of the disease. The model, the structure of the model was a mathematical model, a system dynamics model that you can simulate it. It was a differential equation model and consistent with the ACIR type of models. The outcomes were, first of all, projection about how our next semester will look like. And second, providing a what-if analysis platform for policymakers to test different policies and learn from experimenting with the model. The model structure, as I said, it is consistent with the ACIR model, but there are a few specific considerations. One is that we make sure that we are considering effects of tests in capturing the cases. As you know, COVID-19 includes many cases that have less symptoms and remain undocumented throughout the spread, throughout the infection. Secondly, we included behavioral reactions in the system. The main idea is that as number of cases grows and students and employees learn about those cases, they become more cautious and change their behaviors. And finally, we added this feature to the model that we could change the rate at which people lose their immunities and become susceptible again. But this was a parameter that we can play And we tested different scenarios based on complete immunity after infection, or if a smaller percentage losing their immunities. The model was tailored for a college town where you have a flow of students that are coming into the college at the beginning of the semester, and they leave at the end of the semester. This dynamic can influence the spread of the disease, as new cases can bring virus to the system. The behavioral reaction was coming from cases that were found through tests, and that was influencing risk perception among students and employees, and consequently their contact rate, because if you perceive a higher risk, you may engage in more social distancing activities, which can influence the rate of infection in next time periods. That creates a balancing loop, which is very important and can create all these waves that we see about the disease. Another feedback loop that is important in a university context and prevents the model to go to its extreme conditions of everybody getting infected is that if the cases grow very fast, it is likely that university close early on and students leave the college town. The typical simulation results that you get from this analysis includes a range of bell-shaped curve. In a very unrealistic case, when you don't have a behavioral response, you get that blue line. The cases grow very fast, and many people, almost everyone, gets infected, and then the semester ends. That's an unrealistic case because in reality, we know that people react to growing cases and they may change their behaviors in response. That leads to the other simulation runs. If you have a lower reaction, if the community is not that much sensitive to the growing cases, you get the gray line, which is shown by low response rate. If you have some more level of reactions, you get the red line. And the difference between gray line and red line is that in the gray line, still the university end up closing early on, and that's the reason that the cases decline to zero. But in the red line, the university still is operating based on the closer threshold that you're assuming to the model, and it continues to the end of the semester. And in better cases, you can control the disease by higher sensitivity to risk and better communication with the students. We can look at the cumulative cases under these scenarios and compare them. And as it is clear from the dynamic graphs, you get much more in the scenario that you don't have a behavioral response. We run this model for hypothetical cases. That was the first output that we offered before fall 2020 semester. If you assume that you have 25,000 students and about 3,000 faculty and staff, the model predicts that early on as the semester starts and students arrive at college, you will have a big number of cases, a fast growth in number of cases, and a proportion of them will be confirmed cases, and you will find them through tests, but there is a large number, maybe double the size, that you can't find them, and many people will be infected. We look at other different variables in the system. Cumulative cases show an S-shaped curve as we expect, and predicts about 5,000 confirmed cases and over 10,000 confirmed cases, and over 10,000 total cases in the college town. We similar patterns for active cases. More importantly, we estimate probability of having a case of death among student and faculty, and in the baseline, we find it alarming that there is a chance that we will face a case of death among faculty and staff. The population of the university declines because in this scenario, the model ends up shutting down the university and students leave from this simulated model. That's the reason that the population declines. We also see change in behavior of the students as a response to the growing cases, but that change in the baseline wasn't enough to contain the disease. We run the model for a wide range of scenarios. These are examples of scenarios that I've tested. P1 is proactive testing. That means that we test more people, the capacity for tests is bigger, and we look for asymptomatic cases. P2 is higher mask adoption. And as you see in simulation runs, P2 is in blue, you see that the daily cases decline substantially if more people are using masks. And then we will have a longer semester. P3 is effective risk communication that flattens the curve, but still we have cases. That just leads to be more cautious about number of cases that are around us. And then we also test for remote operation for high-risk individuals to decrease the chance of death among high-risk population in our community. But overall, none of these policies help us to fully contain the disease. Some of them, especially mask adoption, has considerable effects, but at the end, we are facing with the challenge of operation. Now we combine the policies, and this is one of the exciting results that you find from this analysis. We see nonlinear effects. So this graph shows cumulative confirmed cases. These are cases that we find from tests under different policies. So if you implement policy 1, which is proactive testing, you actually find more cases than the baseline, because if you do more tests, you will find more cases. Under P2, with more mask adoption, you find about 15% less cases. And the reason is that total cases are declining, and that helps us to decrease the rate of spread of the disease in the community. P3, risk communication results in more confirmed cases because semester lasts for a long time, and over a long time we have more cases. And P4, remote high risk, is slightly helping us. But the interesting results is here. When you implement P1 and P2 together, when you have proactive testing and mask adoption in the same time, you get the red line, which is considerable. It is about 50% decline in number of cases, confirmed cases, which is considerable, especially if you look at P1 and P2 individually. If you add these two together, you get the gray line. So the effect, the total of effect of each of these policies was actually in the order of 15%. But if you implement those policies simultaneously, you get a synergic effect from them. The reason is that if we have mask adoption, the number of cases decline, and proactive testing can be more effectively spent on finding asymptomatic cases and helping the university operation. Similar results in other combinations of the policies. And if you include all policies, if you implement P1, P2, P3, and P4 all together, you actually can decrease the number of confirmed cases substantially. Similar results for total cases. These are cases that are confirmed or not confirmed. They are the ones that we couldn't find by tests, and these are kind of cases in actuality. You again see that that synergic effect, P1, P2, P3, and P4, when implemented simultaneously, you get much more effect, more than 80% decline in cases. So the finding is that the system is fragile, little changes makes huge difference, and some of the effects is less than effective simultaneous implementation of these policies. And then there is a dashboard that people can use to implement and test different policies in this system. Let's see how the model predicts the trends for the future and how you can compare it with the past data. The blue line here is daily cases, and the red line is the data. As you see, the simulation matches the data, and we only have 3 parameters here to estimate. So the model has a low degrees of freedom, and it fairly replicates the data. The pattern, those waves are coming from the behavioral feedback loop. With more cases, people are becoming more cautious. They're decreasing their contact rate until the semester ends. And then again, you have the same story. In next semester, in fall 2021, the model predicts that there will be cases. It won't be as intense as before because people are getting vaccinated. And that was one of our questions, how vaccination is going to influence next semester. And I'm going to show you the effect of vaccination. In the base run, with the 70% vaccination, we see that still we have cases, about 1,000 cases in cumulative term until the end of fall 2021 semester, which this is a sensitivity analysis for different fractions that are vaccinated and cumulative versus cumulative cases. So if we end up with a higher fraction of vaccination, you see a big impact in number of cases. Basically, vaccination is the leverage point to control the spread of the disease in a university context. In other scenarios that we have a higher infectivity of new variants or less effectiveness of vaccines, we may get more cases, but still vaccination, with bigger vaccination, you have fewer cases. So still vaccination is the key to overcome these challenges that universities are facing. So in conclusion, what I learned from these collaborative works in our university is that just this collaboration, being with the stakeholders, being with other modelers, helps you to gather better quantitative and qualitative data and more accurately develop your models and better respond to urgent problems. From modeling insights, I learned that these behavioral mechanisms are critical in having reasonable estimations for model outcomes. We learned that these policies, when implemented together, they have a bigger effect. And then for the next semester, vaccination is the leverage point to help contain the disease. Then finally, in order to make any impact, any change in a university context, we should work closely with our stakeholders and we should collaborate in our modeling practices to help to communicate these messages. Thank you.